Morning. First of all, I'd like to thank the organizing committee to give me the chance to be with you this year. I'm going to present a short topic about subjective and objective outcome assessment measures in children. We all know that cochlear implantation has considerably improved speech and language outcomes in children with bilateral severe to profound hearing loss. Individual outcomes after cochlear implantation ranges from minimal benefit and awareness of environmental sounds to robust speech perception and language skills. Eventually, if we have two children preoperatively, it's very difficult to know, even if we have full preoperative evaluation, which patient will have a good outcome and which will have a bad outcome and after surgery. So we have to apply efficient outcome assessment measures to evaluate the outcome and to be a cornerstone in the success of cochlear implantation programs. There are many factors that may influence the outcome. First, there are patient-related factors, the age of implantation. If we implant children as early as possible, most probably the outcome will be better. The age of onset of profound hearing loss, duration of hearing loss, regular hearing aid use before implantation, the pathogenesis of hearing loss. If the patient suffers from meningitis or auditory neuropathy spectrum disorder, for instance, it may have a worst outcome. Also, the presence of additional disabilities such as blindness or mental retardation may have an input on the outcome of this patient. In a study done by Professor Jilan Nassar, myself, and Professor Fatma Qaddah, we found that there is high correlation between post-operative rehabilitation speech intelligibility and the age implantation. The age of implantation was the most important factor to predict that this child will have a good outcome. Also, there are factors related to surgery, such as the surgical technique applied, surgeon's experience, device utilized. Also, mapping, speech processing strategy, and map adjustment is very important to predict to have a good outcome. Finally, parents' support and enrollment in effective rehabilitation program. In the same study, we found that there was very high correlation between speech intelligibility and the duration of effective post-implant therapy. There are many outcome assessment measures. Simply, you can classify them into audiological and non-audiological. I'm going to discuss only the audiological, which are subjective and objective measures. The first measure in the subjective measures are the questionnaires, which are very simple and quick. Because parents have great experience dealing with their children, they are observing the child all the time. We rely on them to fill a questionnaire to give us idea about how things are going on after surgery. One of the most commonly used questionnaires is the Meaningful Auditory Integration Scale, the MACE. It consists of 10 items answered by the caregivers. The items are related to vocalization behavior, alerting to sound, and deriving meaning from sounds. It was translated to Arabic, and it consists also of these 10 items. The parents are asked to grade 10 questions from 0 to 4. 4 is the best answer for sure. Then we collect the data and predict the outcome over time. Aided pure tone thresholds, it's very quick and easy and frequency specific, may be affected by the patient, examiner, and equipment, but it should be enrolled in each visit post-operatively. The last item in the subjective measures is the speech perception tests, which is very important. I think it is the most important to monitor any effective rehabilitation program. The development of detection and discriminations of sounds is very important to assemble complex auditory information in connected speech. Speech perception provides direct evidence of assistance provided by cochlear implant system. Accordingly, this is the cornerstone of audiological rehabilitation. I'm going to discuss them briefly. We have the low verbal early speech perception test. This is for kids around 2 years old. We utilize real objects, and it is closed set. We have the early speech perception tests for higher age from 2.5 to 3.5, and it's also closed set. Then the minimal pairs, 3.5 to 4.5 and closed set. We have the common phrases, which we use sentences for older children, 4.5 to 5 years, and it is modified open set. We have the WIPI. We use monosyllabic words, and it is closed set. We have also the PSI, which is single words. We have the PPKG, and finally speech in noise. The child must be seated in a sound-treated room 1 meter from the loudspeaker. We have to do familiarization and practice using auditory and visual inputs before administration. Speech material is presented 55 to 60 decibel. This is the early speech perception test. The first is the pattern perception test. The second is the trochee, and the final one is the monosyllabic words. This is the minimal pairs. There is choice between two words, either constant manner and constant place, and voicing and vowel height and vowel place. And this is the characteristic 6 plates of the WIPI test. This is the most commonly used speech perception tests. It's the importance of conduction of speech perception test. It is the most direct indicator of improvement after application of amplification device when applied at suprathreshold level. And it must be conducted serially to track the performance over time, and it must match the language age of the child. I'm going to discuss briefly the objective measures. We have recently used objective measures because there is unexplained variation in children performance, and also as we implant children at a younger age, it's very difficult to rely on subjective measures. We have to use objective measures. The most commonly used objective measures are impedance testing, neural response telemetry, electric ABR, and P1 cortical evoked potentials. Impedance testing measures the resistance to current flow. It's first used intraoperatively. The impedance usually descends down with time. It's not uncommon to find short circuit or open circuits and high impedance. When we find this, we have to adjust our map and to block electrodes with this high impedance. This figure reveals normal impedance, and the other is high impedance at all electrodes. Then the NRT, it is the most common objective measure utilized. It's measurement of the compound action potential. We use the programming unit and place the magnet over the operation site, and we record it. And this is the characteristic feature of N1P1. It is used to determine that auditory nerve is responsive, and to assist in pediatric programming and provide information for verification and monitoring. I'm going to move a little bit fast. The electric ABR also can be utilized. There are 3 waves that can be recorded, wave 2 and 3 and 5. It is have short absolute and interpeak latency and large amplitude. It is very important to assess the device functionality and to assess long-term functional integrity of the auditory pathway. The P1 also measures the cortical evoked potential, and it is important in clinical biomarker of the central auditory maturation in children with hearing loss and fitted with cochlear implantation. There are many variables that may affect the development of cortical evoked potentials in cochlear implant users, which is the regular use of hearing aids preoperatively, intensive rehabilitation they received before CI, and early age of implantation. The suggested workout in intraoperative, we use first impedance measurement, then NRT and the radiological studies to confirm that the surgery is okay. Postoperatively, we use warble tone aided thresholds. Then we administer Arabic speech perception test according to the age of the child. Also, NRT and impedance should be applied Finally, speech and language assessment and other objective tests in selected cases, and follow-up should be done every 3 to 6 months. In conclusion, as we use multi-channel cochlear implantation, especially the effective outcome measures should be applied to detect efficacy of implantation. Both subjective and objective measures must be utilized and combined to
Dear
assess
doctor,
performance.
your time is up.
Okay, device integrity and functionality is usually assessed by objective outcome measures. Thank you very much.